Our whole world has changed, and it cannot be as simple as eat less, move more. I've changed nothing, and I just turned 45. What's happening? It's the medications we take. It's really our whole environment, and we've got some big problems. Obesity is a disease. Being obese is a state of being. There is so much bias that remains in medicine, you would not believe it.
What are the hormonal disruptions that lead to obesity?
So the biggest one that we can identify easily on lab tests is...
Dr. Sowa, welcome to the show.
Hello, thank you for having me.
I'm so excited. This is such a long time coming. I'm literally on the edge of my seat because I have so many questions for you. I've been following you for a while. And, you know, for us who kind of do this medical education on social media, like to get to meet each other, like IRL.
I know.
So special. So I always like to have you introduce yourself because you know your story better than I do.
Yeah.
But introduce yourself and kind of set the stage for what we're going to talk about today.
Okay, so I'm Dr. Alexandra Sowa. I'm a dual board certified internist and obesity medicine specialist. I have been practicing obesity medicine for well over 10 years, exclusively at this point.
Wow, exclusively.
Exclusively.
Which is important.
Yes.
Because I have to interject, you know, I exclusively do like midlife and menopause and hormones. And that means you see everything. And so I just want to set the stage for, you know, as you're going to talk in this show, you have so much, you know, Dr. Sowa has so much deep expertise in clinically what happens. And this piece is really important because you hear a lot of noise on social media or you're getting advertised to. And so I have to set the stage to say exclusively only doing this for 10 years is huge. All right, continue with your introductions.
So you might say, well, how did you get into this before anyone knew what this was? So back at my training at NYU, which was outstanding, I became pretty disillusioned actually because the majority of our education was focused on end of disease management. And we knew that taking weight off would help with some of those diseases, but we didn't have a lot of tools to give people. And I myself come from a family of women specifically who carry significant excess weight despite all of their best efforts. And so I grew up from a very young age knowing that this has to be biology. This is not willpower, because if it were willpower, these women around me would be thin. And somehow I emerged without disordered eating, but with a really clear perspective on what this did to people and how it affected them. So when I found the very baby nascent field of obesity medicine when I was in residency, it was like a light bulb went off.
We are kindred spirits. Same thing happened to me 10 years ago in menopause.
And everyone was like, you're crazy. Okay. And I was like, no, there is a body of emerging evidence. We have medications. We have tools. I'm going to study this. And they said, oh, so you're going to go be a surgeon. And I was like, no, I'm not a surgeon. I'm not going to be a surgeon. There are other ways to help people. And what really I found was that it had to be so much more than a handout, right? Or a prescription. And I just knew that we needed to work on the whole of the person. So I was really fortunate that in my DNA, I was like, I'm going to strike out on my own and create a really unique practice that's very holistic. And through that practice, I've really developed a method that, you know, I put into a book to help people that's very holistic with these medications. And I feel so lucky that I do what I do.
The kindred spirits again. Like I'm getting goosebumps. I say that too. I wake up every morning. I'm like, I can't believe I get to do this. Like I get to talk about my favorite topic, treat patients, teach about this. Okay. So I know everyone listening or watching really wants to know about the medications, but before we get there, I really think we have to do our due diligence in, like you said it's not willpower. There has to be some biology. So before we get to the juicy stuff, I know everyone wants to know, we have to set the stage, I think, of what's happening metabolically. And you're going to do a good job of explaining that because I was going to add in some things. And as I started, I was like, I have an expert right here. So tell me like, what is this biology?
So there is some genetic component to what weight you might manifest in your adult life. But what really the big thing that's changed recently is epigenetic modification. So it's the change on top of the genes that we carry. Because people will be like, oh, no, but we didn't see this in the 1970s. You are correct. We did not. Prior to 1980, we only had about 10 to 12% of the population that kind of met obesity criteria. They were kind of the ones with the genetics. My family, right? And then on top of that, what's happened where we've gone to about 50% of the United States population approaching obesity BMI rates is our whole world has changed. And it cannot be as simple as eat less, move more. It's not just the food. It's a big part of it, but it's everything else. It is silly things like we're temperature controlled now. We're never hot nor cold, right? And we have easy modes of transportation. And we just don't have to work as hard in our day physically to get things done.
You hauled it all the way up to this podcast studio.
I did. If you see the sweat, it's because I was late. I had to. But, it's the plastics that our foods are wrapped in. It's what the toxins in the air. It's the medications we take. It's really our whole environment. And we've got some big problems. And I'm not saying we shouldn't work towards solving them by any means, but we cannot expect the individual to take on the entire burden and figure it out for themselves. And so really it's multifactorial is what we say. And so genes are a part of it. They'll change on top of the genes. The epigenetics is a part of it, and our environment, including food and movement and all that stuff that we typically think about with weight.
So I love epigenetics. I kind of got this little nerd moment when you said it, and you write about it too. But it's kind of like how to explain it. I was thinking how to explain it. You did a good job, but it's almost like if a gene is, I don't know if kids do Minecraft, right? It's like a block. Epigenetics kind of, it says it has an information in it, but epigenetics almost like turn that off or turn it on. So that's exactly how you were saying back, decades ago, they would just know what genes you had. They wouldn't necessarily know if they were on or off or to what degree.
Exactly.
And epigenetics is wild and fascinating. So there is this biologic component. There is this change in the way we function as humans, the way we move or don't move, the food that we get and things like that. So I really think it's interesting changing the language to the person saying, we're moving away from, instead of saying the person is obese, we're saying the person or patient has obesity.
Yes.
And talk about that and sort of what does that shift really signal and what does that mean?
I'm so glad you brought this up. Of all the podcasts I've done, all the press for this book, no one's ever asked me that. And I'm very, very intentional about the language I use. And when we went through in editing this book, there were a few of the copywriting edits went back and I said, no, we are not using that language. It matters. Why does first and purse language matter when we talk about this? Because obesity is a disease. Being obese is a state of being. And that puts blame on the individual. This is a disease. So in talking about the genetics, epigenetics of it all, really what's going wrong? Obesity is, this is a big one, but I like to explain it this way. Neurohormonal dysregulation.
Ooh, say it with me. Neurohormonal dysregulation. Okay, break it down.
Yeah. So our body is just like in menopause management, our body is run on hormones and signals from the brain to the rest of the body. And we used to think that the fat we carried in our body was just related to the food we take in, but that is like such a small part of it. And what's happened in this world around us, and as we age, our body responds to hormones differently. So if we grow up in a world where we're just eating hyper palatable, delicious McDonald's food, all that stuff, our hormones actually change and the response in our brain changes. So we might no longer be able to understand hunger cues. And our body says, that seems like food that I should just put over as fat rather than even keep it for burning, even if you go for a run. So it's really a series of hormonal shifts that happen to us. And so when we talk about obesity, it's a disease. And it's just like any other neurohormonally dysregulated state. So if you have high blood pressure, it could be related back to hormones. We're going to treat that blood pressure. Or if your thyroid starts to become sluggish and we give you a medication to treat your thyroid, we don't go around calling you identifying you as like hypothyroid, we're like, oh, you have hypothyroidism. So it's the same thing.
I actually, the first time I did hear this kind of changing connotation, like something immediately was like, in my body, because I think, being a resident and, doing resident clinic and all of that, you do see obesity as it presents as a disease. And like a lot of these patients are working so hard. Like it's obvious, just as you said, you became disillusioned that like, it's not just willpower. They have so much willpower now. They're just depressed because it's like not taking them anywhere. And it felt like a relief off my shoulders. And I always think like it would be like calling somebody, instead of saying they have hypertension, like they just have really bad blood vessels. It's just, so I think it's really all encompassing. I felt a lot of relief when I heard someone first say that. And I've just changed my language ever since. Like it just automatically aligned. So then let's talk about, this is a nice gateway into medications. So there are medications that treat other neural hormonal dysregulations. I'm well aware of some of those. And so what is, like, we have very parallel lives, it sounds like. And so what does that mean for the medications you're using? What are the hormonal disruptions that happen that lead to obesity?
So the biggest one that we can identify easily on lab tests is insulin resistance.
The old IR, insulin resistance.
I love looking for this because 80% of the time if someone comes to me and says, I'm gaining weight and I'm not doing anything differently. In fact, I'm doing everything better.
Yes.
I'm doing it by the book and I'm still gaining weight.
I've hired a trainer and a nutritionist and I'm doing macros.
Yeah. Or
weight.
they're like, I've changed nothing and I just turned 45. What's happening? Generally, we'll see some creeping insulin resistance. So what is that? Our pancreas is this amazing endocrine organ. We need it. We need insulin. It produces insulin in response to carbohydrates, to sugar. When it breaks down, it's the kind of grabs it and shuttles it off to our body. Over time, when we need to make more insulin because our blood sugars are quietly rising, our body can get a little tired of seeing that signal of insulin, and that's insulin resistance. And so we got a confused signal where your body's making more insulin to deal with blood sugar. Blood sugar's rising because it's waiting for more insulin. Your body's saying, I don't like that level. Make more. The problem with that is insulin is a fat storage and a hunger hormone. And so it often can be like the first sign. We have many other hormones that we've identified. GLP-1 is one of them, GIP, and now we have targets to kind of go after that, where we develop a resistance to these. Leptin is another one in the brain where we develop a resistance to it with kind of the modern Western world, and then our body truly cannot ever feel full.
So then by targeting these with certain medications, does it make them sometimes work better or does it just do their job?
So what are GLP-1s? Let's kind of answer that question with the medication management. Is that GLP-1s mimic a hormone that we make in our body.
So it's like giving estrogen when your estrogen's lowering.
Okay. So we made a synthetic version of it. What's different about this versus what we make in our gut is that it is 1,000 times more effective and it lasts. So what we make in our body, and you'll see a lot of companies jumping on this GLP-1 booster train. It really doesn't do anything when it's made within your gut if the hormone that if the place in the brain that it's supposed to respond to has a resistance, making a little bit more of it doesn't. But these medications are in the thousands of orders stronger, and they last a long time, and they're not degraded in the gut within order of seconds to minutes.
Got it.
So these hormones, we have receptors all over the body. And that's the phenomenal thing about these medications.
I know. I was just thinking how much I couldn't wait to ask you about the whole body effects because, so to summarize, we've got, we're replacing a hormone that we might be losing, that we've gained resistance to. There are some epigenetic changes, et cetera, or maybe you have a genetic predisposition. So we're going to replace it, which sounds like a lot like replacing estrogen or progesterone or testosterone. And, you're talking about using doses that are now FDA approved. And because of that, they have receptors all over in the body. So they probably do other things besides for weight. So how does it impact the whole body and then lead to weight loss?
Yeah. So I call them superpowers in my book. And they work in 3 ways. They talk to the brain. They say, brain, the resistance you develop to not understanding your own hunger cues, we're not going to turn up your hunger all the time. So you're just going to think about food less. You're not going to want it as much. And then that's a very simple version. We see a lot of other added benefits to what people don't want in excess in their brain. And then in the stomach, we slow down stomach emptying time. So food sits there longer, and it's kind of like a mini bariatric surgery effect where if food's sitting there longer, then the hormones going to the brain are saying, I'm full, and your brain can now recognize it. And then finally, it acts on the level of the pancreas. So that important insulin blood sugar relationship is optimized, and your body is able to tap into its own fat stores for fuel, not just needing what's in front of it and telling you to eat more carbohydrates and food.
Wonderful. So brain, gut, pancreas.
Yep.
Okay. And so, you've got these receptors all over the body too. So I love, because as a clinician, I again see this with a lot of my patients. I do a lot of hormone therapy, but I do some GLP-1s. So I see them come back and say, gosh, I feel like my brain fog is like really now gone. That the hormone therapy helped a lot, but this just took it away. Or they'll say, my mood is actually really good now. I just feel just content and happy. Or my joint aches and pains are gone. So is there some truth to this?
Yes. So we have receptors everywhere, in our heart, in our lungs, our gut, our brain, our skin. Our taste buds. I mean, it's truly remarkable. And that's what makes this medication so different than our first generation anti-obesity medications, where they really just targeted like one thing. Really were focused on appetite. This is systemic.
Yeah.
And that's where we see all of these emerging benefits. I'm going to address everything you just said, but we have proven benefits now of decreased rates of 16 types of cancer. Significantly decreased mortality from heart disease and all-cause mortality. We are just, honestly, I think very soon we'll see proof that we have decreased rates of dementia on this. And why? Because overall we're reducing our blood sugars, and blood sugar is inflammation. And so at its root of a lot of the things that people are talking about, I feel inflamed, I just generally felt sluggish. When blood sugar stays stable like this, you get to see this cascade of benefits in the immediate. And then it acts on the cytokine pathway of release, and we see a decreased inflammatory effect across the board. A lot of the things that people report on these medications have yet to be fully validated in large-scale data, but we're slowly starting to pick it out. I mean, these meds are so well studied, and we have such a body of literature and people on them. So I'm excited for what is to come, but it's thrilling.
Yeah. What a time to be alive. Like for the two of us, like, yes. So, is there a room for, there's other medications that you probably, prescribed. I know GLP-1s have been out a lot longer than the last couple years. That's just when we've kind of heard about them. I mean, like, I remember prescribing Byetta to at the VA forever. When I was like a resident, like 2008 or something, however long ago it was. But is there still room for some of the older medications? And I know, of course, this is individualized. I know we're like twin spirits in that, but for some of the older medications like Contrave, Qsymia, et cetera, or even the old Adipex, what role do those play now that we have semaglutides?
I love them. Yeah. And I talk about them and I educate about them because unfortunately GLP-1s are cost prohibitive to so many, and we have not solved that yet. So I can go on and on about how amazing these medications are, but if they're out of reach, they're out of reach, and we have a problem. So I'm always telling people, don't forget about the other tools. So just this week, I had a young patient who lost significant weight with me, and she changed jobs and her insurance dropped coverage. And so we kind of laid out all of our options. And what we settled on was going back to one of the older generation medications. So phentermine, people get scared of it. They think of fen, right? That was a different drug. That's not phentermine. Phentermine is a well-studied appetite suppressant that we've had for decades and decades. And with a little bit of oversight, we just need to make sure heart rate doesn't go up or blood pressure, but it can be very effective. It just decreases appetite. So instead of just fully going off of a medication and rebounding, we can use that. Metformin is another wonderful tool, an underutilized tool.
I love metformin.
So
I use it a lot.
It will never get classification as a weight loss drug because it's generic and it's cheap and no one's going to study it. But when we look at the literature, people can lose on average about 6% of their total body weight within 12 months on the medication. So that can help us if we need a little boost to the GLP-1 or if we need to come down or off of the GLP-1. I love Contrave for the right individual. Contrave is a combination of Wellbutrin and naltrexone. And so when cravings and overeating and kind of just an emotional draw to food is kind of right in front of us, Contrave is great. I will often layer medications alongside GLP-1s too, because it does need to be personalized. And so sometimes, some
hormones, we call this hormone stacking in my world.
I love that. I was just watching a video of yours about that, and I was like, That's
this
what
is exactly what you do.
And I'll never do anything, two things at the same time. I'll be like, we're going to wait, and then you're going to stack it. Yes, I'm taking that.
I know. This is like in real time. Like our parallel lives are coming together. They're like meeting like a moth to a flame. Yes. But that's exactly what that is. That's hormone stacking. You just told me it's a neurohormonal dysregulation, right? And when you do one at a time, you supplement with them. That is so amazing. So the next question, I know the answer. I think I know the answer, but I want to hear from you. And you must get this question all the time. Going back to the GLP-1s and how much benefit they have. Well, should everyone be on a GLP-1?
Yeah, that's a great question. So, yes, the answer that I hope you know is no, but it does get more nuanced than that. So we do see all of these longevity benefits. We are at a point in time where our life expectancy has actually been going the other way, right? We are not very healthy as a collective whole, and these medications prevent progression and treat the end stage disease of a lot of things we face at the end of our lives. So I would never, ever say that we should all be on them, but right now, 1 in 8 Americans have tried it. And as this drug...
1 in 8?
Oh, yes.
Wow. Mm-hmm. Okay. Wow, yes. Wow. I feel like sometimes from a friend. I've heard, and again, I'm, going back to like the price and who's a good candidate, but these are just things that my patients will tell me the things, you know?
Yeah. And so I think this medication will come to look like statin therapy, where at a certain point when we know that rapid aging kind of takes over and insulin resistance sets in and we're on a path to diabetes and we have known heart disease or we have sleep apnea, which all of these things are now approved. These medications are approved for treatment.
Wonderful.
We will go there as first line. And so at a certain point, yes, I think we're going to move toward that.
Do you think they will do studies to see if this would be almost like, for primary prevention?
Yes.
Are they ongoing right now?
Well, I think we're starting to look at some of this data. When we pick out the disease and you're just treating for weight.
Yeah.
They're amazing. They're revolutionary. I love them. My fear, though, when we have this conversation is that there's a lot of money behind these drugs and a lot of people trying to sell you them. And they feed on our insecurities. And so there's a difference between a fountain of youth versus an amazing drug that helps treat and prevent versus a drug that's just going to make you very skinny. And these all get wrapped up and can be very, very dangerous.
Yes, I see. For anyone who's listening, we got a little excited about talking about primary prevention. We should talk about what that means, I guess. Primary prevention means that a medication, if you have, X, Y, and Z risk factor, there's proven data from long, ideally randomized controlled trials. So this will take a long, long time till we even get there, that starting it can help you ever preventing, let's say, a heart attack, right? So for those of you listening, some patients will be prescribed statins for the primary prevention. Now, secondary prevention is when you've already had a heart attack. So we want to prevent a second heart attack. And so the idea of having GLPs be prescribed as primary prevention would be quite revolutionary. But then let's dig into, so then there's this overlap between, who is it right for? And we are getting so much marketing for them because of just these insane benefits. So that is a question I'd like to ask you. What do you think about compounding? Let's start with that.
Well, I think this comes back to the fact that these medications are very expensive and they're often inaccessible. So there is so much bias that remains in medicine, you would not believe it. So many people qualify for these medications and the doctors are like, I don't trust that drug. And I'm like, I don't understand. Did we all go to the same medical schools? Because where are you in understanding literature?
Right.
And so they'll turn to places that make it very easy to get the medication, but without a lot of support. Right. And compounding medications kind of came out of this duality of lack of access.
Ooh. Do you know what else this reminds me of?
What's that?
The early 2000s when the Women's Health Study came out. And so lack of access and, need for it drove people to get hormone therapy to be compounded. Oh my gosh.
I know.
My brain, I have the exploded brain emoji as you're talking.
There are so many similarities, unfortunately. And I think it all comes back to stigma.
Yeah.
Fundamentally, it just comes back to stigma of treating things that we don't want to treat. And they're primarily female-centric. So we can film a whole other podcast on that. But so compounding. I love a good compounding pharmacy. We can use them across for indications all the time. These meds are a little different. They're very complicated to make, the injectable versions of them. And we had a little loophole with the FDA when we were in short supply that some compounding pharmacies could go around the system and make this drug, even though it was on patent. And now they cannot. And so I really warn people of making sure they're getting their medications from the source, from an FDA-approved facility. And right now, they're brand name drugs. What will be very interesting is that out to market next year in 2026, we should see the first oral non-peptide version of this drug, of a GLP-1.
Give us a little sneak peek on what that would look like.
So orforglipron.
Okay.
Such a mouthful. I can't wait to know what the brand name will be.
I wonder what they're going to nickname it on TikTok.
And
the GLP.
Yeah, exactly.
You heard it here first.
So why this is so special is we've had other oral versions of the drug.
Like
they're
Rybelsus.
They're hard to tolerate, and they're still hard to make, so they're not affordable. So the peptide element of this makes it so that it's complicated. So we can't easily make this in a compounding pharmacy like some other drugs, right, that we go to and use. This one might be a little different. And so come back to me in a year and see. Now, it'll be on patent still, but it opens up the pathway. And my hope is that when this drug comes to market, it will be affordable from the jump.
Oh, that'll be great.
Yes.
Now, I know that you could talk about this for hours, but briefly, what are the differences for listeners between some of the different semaglutides? You know, people have probably heard of, or maybe not, but Ozempic, Wegovy. Right. Now we've got Mounjaro, which is a big fan favorite, it seems to be. There's the oral Rybelsus. You know, very briefly, without kind of doing a deep dive, because read the book, but, you know, what are the differences between?
So when it comes to weight loss, the first injectable medication, we had the first FDA-approved medication, was actually a daily, was liraglutide Saxenda, a daily injectable.
Gosh, that brings me back to residency.
Yeah.
Yes.
So listen, I love it.
Yeah.
We have had this little loophole with the fact that it went off, a problem where it went off patent, and then we're all like, yeah, it's going to become affordable. And then the people who are supposed to take it over, it's been expensive and delayed. But I'm looking forward to that one coming back and being a more affordable option.
That would be great.
For the right people, that drug works very well.
Yeah.
Now, we didn't really start hearing about these meds until we had the weekly versions because they are much more efficacious.
Right.
People were just like, wow, this really works. And it does. It works better than our daily versions. It lasts longer.
Okay. Higher doses last longer.
Yes.
Kind of thing.
Less side effects.
Yeah.
And really, we're just seeing double, triple the weight loss of what we were seeing on Saxenda.
Yeah.
So Ozempic was first. Colloquially, we call it that, but we know better now, even since the title of my book came out.
Yeah.
So semaglutide or semaglutide, how people say it. So we have Ozempic and Wegovy, and it's a daily injectable medication. The thing about this, people always talk about microdosing, and it kind of annoys me because it's a made up term.
I know. I had to ask you about it.
Yeah. With Wegovy, the FDA says the full dose of Wegovy, up to 2.4 milligrams per week, is where you should be for weight loss. Not everyone needs that. And so and it's kind of hard to keep people on the lower doses, honestly, because insurance companies give you big pain about it. It's so annoying. But I try my very, very best. And Wegovy is an auto-injector medication versus Ozempic, same drug, but it's like a little click technique, and you can break up the pen for lower doses. Ozempic is for diabetes. Wegovy is for weight management and it has FDA approval now for secondary heart disease prevention. And then we moved on to, later came out the dual agonists, GLP-1 and GIP. So we have Mounjaro, and then we have Zepbound.
Yeah.
And people love them for a few reasons. They are overall more efficacious. And generally tend to have less side effects. So people feel more like themselves. But I will say, some people, I've switched over to the dual agonist, and they loved the way Wegovy made their brain feel. And they're like, please put me back. Yes.
I can vibe with that so much. Some of my patients, they'll sometimes switch from patch to gel. I do love how I used to bring it back. And, you know, there's sometimes no rhyme or reason. We don't know who is going to do better on which ones.
Nope. It has to be individualized. My hope is that we're going to have this amazing pipeline. We'll have so many options, and there will be a way to almost test that genetic, epigenetic arm, being like, you'll respond here.
Predictive medicine.
Exactly.
I can't with you. I can't. The similarities are just growing and growing and growing before my eyes. That would be so wonderful. Yeah. So what do you think about all the, there's poaching in my world, right? So what do you think about all the, I don't know if poaching is the right word, but certainly there's a lot of telemedicine companies coming up in both of our worlds, and they really have this nice Venn diagram of weight and midlife and menopause, and then where the two come together. But I'm seeing a lot in my space. You probably are seeing a lot in your space. My patients who come to me tell me they've been using some of these companies. What are our thoughts here? What should we be thinking about? What would you advise women who are listening to the show?
I think it's hard to find good doctors.
There's not enough.
I'll advocate for my specialty. You can go to www.abom.org to find an obesity medicine doctor. Ooh. They're out there. They're near you. I love that as a starting place.
Yeah.
But we have to turn sometimes to asynchronous platforms. I love this one app for my kids that I use all the time. I love it. So we can do this well. Yeah. What I would like people to look out for is that a lot of the asynchronous telehealth platforms, they're not checking labs. That's like a big red flag, in my opinion, and I know it's the same in the menopause space. I need to know where we're starting, and I need to know what exactly we're treating so that we can know how and why you improved and what the future looks like. Yeah. And then the next thing is I want to make sure you're getting holistically managed and that someone is really taking care of not just your body and your labs, but your brain. And you're really supported. So I want you to look out for that too. And then finally, I want you to stay clear of these companies that are trying to sell you on skinny. Run so far away. I have been seeing ads that are saying, BMI, we don't have a requirement. Or, oh, don't worry, you're a normal BMI and just want to be skinnier, lose that last, 10 pounds of baby weight. Not that they're targeting me about that. I'm still dealing with that. But, run because that is not healthy. That is not what these medications were intended for. And you will be far less healthier for it. Yeah. We have to worry about our bone composition. We have to worry about our muscles. We have to worry about our basal metabolic rate. We have to worry about what you're eating. And I really do worry. I love these medications, and I've been standing on a soapbox for years telling people that obesity isn't a moral failing. It is a disease, and we should have access to these drugs. But at the same time, we now have to be very careful about how we talk to the next generation about them. Yeah. And how we, I want everyone to neutralize bodies. I want to be so body positive. Yeah. And I worry that now, with especially the rise of places where it's so easy to get the drug. Yes. You don't even have to talk to anybody. Yeah. Let's make sure we're doing it for the right reasons.
Well, and I'll go out on a limb too, alongside you here, and add to that and say, look, a lot of these companies are venture backed, and that means that there's a goal of selling you these things. Because when a company is venture backed, that means that whoever owns that company really needs to 10x the revenue of their company. How are they going to do that? Sell you things that you don't need. And I see this a lot as well in my field as well. And so knowing sort of what is and the other thing too is they're marketing machines. Yeah. They've got a lot of money. They also need to 10x their revenue, but they take all that money and they market directly to you. We're all the clinicians on, what's the website again? Let's say it again.
www.abom.org.
Okay. abom.org is not as sexy as the Instagram ads that come right up that just know exactly your pain point, know exactly how to make you click. And so we have to talk about the impacts of companies that have big marketing engines versus us clinicians who are on the ground. I bet you that there is plenty of obesity specialists, clinicians who are well trained. Yeah. And this is a much, much, much better option. And I think you're right. Just like now we're talking about cell phones. We're like, oh gosh, we've been in cell phones now, like social media, like maybe 10 years deep. And we're like, I bet this has an effect on our kids, right? I bet this has an effect on our mental health. I bet this is having long-term effects that we got so excited about having all this fun stuff for a while and we were so entertained. We kind of forgot about what is this doing to culture and society? But I want to end on that because I think you probably think about that a lot.
Think about it a lot.
Yeah.
So sometimes people will tell me that in my field and with these medications that I'm putting a Band-Aid on a systemic problem, right? And it kind of goes back to this idea that this problem is bigger than us. Mm-hmm. My hope is if we do this right, these medications allow us to turn back time and allow us to undo the epigenetic changes and the systemic changes. They give us pause to say, how can we look at our towns and put in bike paths again? How can we have healthier food in the lunch line? You know, it kills me. My kid came home. I realized he was ordering all these sugary drinks at lunch. I was like, you know better. Why is this even here?
My second grader told on my fourth grader who said, you know that my sister drinks chocolate milk every day for lunch. We had no idea.
You know, it's like making those small changes that allows us to, instead of focused on the end of disease management and dealing with how to deal with a population that's just getting sicker and sicker, how can we focus on keeping us healthier? And so my goal is that we have to use this responsibly. We have to use it ethically. And the goal here needs to be long-term health.
I just got goosebumps because it gives us a window to do that.
Yeah.
Right. And as we're all feeling better, and if we're using them responsibly and we have good clinicians and we have good science and understanding, we could do this work. We could regain some time back.
Yes.
We could regain some health back to be able to do that.
Yeah.
I love that so much. Well, where can people find you? And tell us a little bit more about your book.
Yeah. So you can find me on Instagram, Alexandra Sowa MD, and on TikTok too.
Yeah.
I think the TikTok girlies like me a little bit more over there. So you can find me over there.
Yes.
And you can find, and I run another company too, talking about companies that are supporting people in GLP-1 spaces. I have a company called SoWell.
Yes.
And so you can find us at getsowell.com.
Wonderful.
So we've created a whole ecosystem of product that supports people, everything from the book to products that are made to decrease your side effects and make you feel better.
Yeah.
And so I'm just on a mission here to just make this kind of normal and healthy and safe.
I like how you're really weaving this in with the hopes and the promises and the excitement and all the good things about this, but also thinking long term. Who is the right person? How could this potentially be abused? What studies are we looking at? And so I think that is the whole picture here. Yes. It was so wonderful to have you on the show. I think I'm going to have you back for a part 2 because there's so much more to talk about. But thank you so much. Such a wonderful episode. And I can't wait for part 2.